There is a RP atrophy area temporal to the fovea, and there is a neurosensory detachment at the macula. This is an autofluorescent picture. In the right eye, we can see multiple hypofluorescent areas. In the left eye, we can see a large hypofluorescent area which is corresponding to the area of RP rip, surrounded by an area of hyperfluorescence which is due to retracted RP. This is an OCT image of the right eye. We can see there are multiple neurosensory detachments with shallow pigment epithelial detachments. This is an OCT image of the left eye. There is a shallow subretinal fluid at the macula, PED temporal to the fovea with retinal pigment epithelial rip at the dome of the PED, and there are rolled out edges of the RPE. This is a fluorescein angiography of the right eye. We can see multiple pinpoint areas of hyperfluorescence which increase in intensity in the late phase. This is an FFA image of the left eye. We can see a well circumcised area of hyperfluorescence in the early phase, which is corresponding to the loss of RPE, which increases in intensity in the late phase with a narrow portion of blocked fluorescence on the inferior margins, which is consistent with the retracted RP. So come to differential diagnosis that the patient may be suffering from Vogt-Cohen-RD Harada, which is ruled out here because the patient is not suffering from pan-uveitis or any extraocular manifestations. Could be suffering from sympathetic ophthalmitis, which is ruled out again because there is no history of trauma. The other causes could be posterior scleritis, choroidal tumor, or uveal effusion syndrome. So my provisional diagnosis is the patient is suffering from bilateral central serous chorioretinopathy with left eye inferior bullous RD with RPE rip. Focal laser was done to discrete the leakage areas in both the eyes. Spontaneous retinal pigment epithelial rip has been reported more commonly in association with neovascular macular degeneration post-trauma with intravitreal anti-VEGF injections in CSR. RP rip usually occurs at the junction of detached and flat retinal pigment epithelium. Tears were first reported by Hoskin et al. Reports of RP defects in association with CSR are rare. Steroid usage is an exacerbating factor. Our patient developed a spontaneous RP rip with CACR without any history of steroid use. Another interesting fact is that the RP rip was seen at the dome of the RP detachment and not at the edge of the PED as seen in age-related macular degeneration. So I conclude here by saying that the bullous retinal detachment is a rare manifestation of chronic central serous chorioretinopathy. RP tears may rarely occur in CACR, particularly when the neurosensory detachment is associated with underlying PEDs. Due to its peculiar clinical findings, it can represent as a diagnostic dilemma and lead to inappropriate management. Treatment of bullous CACR is still a matter of controversy. Failure to differentiate bullous CACR from other diseases may result in inappropriate uses of corticosteroids, worsening the clinical picture and leading to a poor visual outcome. Further studies are mandatory to address this issue for improving the patient's care. These are my references. Thank you.
What was the cause of CSR in your case?
So it was a spontaneous, there was no usage of steroid by the patient. It was a spontaneous cause. Other than that, sir, he was not suffering from any personality disorder. The age was also, maybe age could be a factor because he was a middle-aged man. So we consider that the cause could be a spontaneity because of the age. There was no other factor.
Have you noted that pachychoroid in your OCT?
Sir?
Pachychoroid
No, sir.
on OCT?
In this picture?
These are pachychoroid or bullous
So
size of the choroid and choroidal vessels.
So
Is it the cause?
Not a pachychoroid, sir.
This is not a pachychoroid?
No, sir.
Okay.
So why you are saying this is a spontaneous?
So because the other causes couldn't be ruled out because we say that RP rip is usually seen in patients.
What other causes you have ruled out in this case?
So like I said, he was not taking any steroid medications. Usually patients who take a steroid, they are like an exacerbating factor in cases of RP rip. But this case, he was not taking any steroid medications, so probably the cause could be spontaneous.
Did you take any previous history of treatment of this
Yes,
patient?
sir. I took a previous history, but there was no history of any previous attacks like that.
You feel that the steroids causes the rip or steroid causes the CSR?
So steroids causes CSR.
What can cause the treatment?
So treatment of rip. So we, so see in this case, as we can see, there is a subretinal fluid. So basically, patient was given a laser treatment to just discrete the areas of leakage. And after then that, sir, we followed up the case for 1 month. He was not a very
We have given the laser treatment, but
yes, sir.
is there any history of laser in the past?
No, sir.
But it's a chronic CSR.
Sir?
It's a chronic CSR, isn't it?
Yes, sir. But he didn't seek any treatment. He didn't give any history. So we told the patient just to come for a follow-up in case there is a subretinal fluid again, and we advised him for surgery like external drainage device or for oral treatment. But we lost the follow-up of the patient after 1 month.
Other eye is also having CSR. How will you manage?
So the management options could be, first of all, we could wait and watch if there is a worsening of the visual acuity. But other than that, if there is still a persistence of subretinal fluid, then we could go for other treatments like external drainage devices, and we could also go for oral treatment in the form of eplerenone.
Sandy, you said that it's not pachychoroid. Did you all measure the choroid?
Sir?
Did you all make measurements of the choroidal thickness?
No.
So it looks like, looking at the OCT, it does look like pachychoroid, and we all know that now CSR is a part of the
Right,
pachychoroid spectrum.
Right, sir. Right.
So that's something that you should also,
Okay.
especially with such bilateral
Okay.
cases, it's a good
Okay.
idea to measure them.
Sure, sir. Okay.
Good, thank you. Next speaker is same one, Jasmeet Chand. Yeah, yourself. You will be presenting on bilateral foveal photoreceptor disruption in young male.
Yes. Good afternoon, everyone again. Myself, Dr. Jasmeet. I'll be presenting a case of bilateral isolated foveal photoreceptor defect. An 18-year-old male presented to our eye clinic with the chief complaints of progressive bilateral loss of vision since few months. There was no associated history of any pain, swelling, or redness of the eye. So the timer is not on.
Timer, you can start.
Okay.
Where is the timer? You cannot see the timer.
There was no history of any trauma, drug intake, or sun gazing. There was no significant past or family history, and he was not suffering from any systemic illness. Stop.
You can start. We have started. Keep continuing.
On ocular examination, the best corrected visual acuity in both the eyes was 6/36 with minus 0.5 diopter cylindrical lens at 180 degrees. The slit lamp examination of the anterior segment was unremarkable. The IOP was 14 mm of Hg. Gonioscopic examination was normal. On extraocular movements, there was no restrictions in all gazes, and on color vision, it was impaired for plates 7 and 16 on Ishihara chart. This is a posterior segment examination pictures. This is a fundus photograph of the right eye. The media is clear. The CDR ratio is around 0.3. The vessels are normal. There is a blunted foveal reflex, we can see here. This is a fundus photograph of the left eye. The CDR ratio is around 0.3. The vessels are normal. There is a blunted foveal reflex seen. This is an FFA picture. The figure A and figure B shows an FFA image of right eye in the early and the late phase. In figure C and figure D, we can see an FFA image of the left eye in the early and the late phase. No abnormality was detected here. This is an OCT image of the right eye showing foveal thinning, loss of subfoveal ellipsoid zone and interdigitation zone with intact retinal pigment epithelium and no hyperreflectivity in the outer nuclear layer. This is an OCT image showing foveal thinning, loss of subfoveal ellipsoid zone and interdigitation zone with intact RP and no hyperreflectivity in the outer nuclear layer. This is an OCT angiography of the right eye and the left eye showing normal superficial and deep plexus. This picture shows normal RNFL pattern. So the investigations done were NCCT brain, but no abnormality was detected. So I come to differential diagnosis that a young patient with bilateral diminution of vision and apparently normal fundus could be suffering from occult macular dystrophy, optic neuropathy, which is ruled out here because the disc margins are normal and the NCCT was normal. He could be suffering from amblyopia, cortical vision loss, functional or non-organic vision loss, vitreomacular adhesion or traction, blunt trauma or photic retinopathy. So come to a provisional diagnosis that the patient is suffering from occult macular dystrophy in both the eyes. Occult macular dystrophy causes progressive loss of sight due to loss of foveal cones, leading to loss of visual acuity and color vision. Primarily it affects the fovea, and more generalized cone dysfunction is usually not present. The anterior and the posterior segment examinations are normal. Diagnosis of the disease is usually late because of the normality of the fundoscopy. Even in advanced stages, it remains unchanged. There is an abnormal focal macular ERG seen in this case. This image shows different stages of occult macular dystrophy. There are basically 3 stages. In stage 1, there are minimal structural changes. In stage 2, there is a structural change which is basically through the fovea. In stage 2b, the entire macula is involved. In stage 3a, the ellipsoid zone is flat. In stage 3b, the ellipsoid zone is disrupted. We can see the magnified image on the left side. These are the conditions which are associated with autofoveal defects. These could be posterior vitreous detachment, lamellar macular hole, macular edema, blunt trauma, ocular macular dystrophy, etc. This image shows a posterior vitreous detachment. In figure A and figure C, this is the image of the right eye showing the detachment was complicated by the occurrence of autofoveal microdefect that improved over time. And figure B and D is of the left eye, which shows there was no change despite the separation of the posterior vitreous from the fovea. This image is of ocular trauma. This causes autofoveal microdefect. In figure C, we can see a phototrauma due to a laser pointer. We can see a gray hue. And figure E, we can see a phototrauma due to eclipse viewing. Last figure, figure F, shows an autofoveal microdefect which is associated with thick choroid in an 83-year-old female. So I come to a conclusion that for all patients with normal appearing fundus and a vision decline, the differential diagnoses include retinal degeneration such as cone dystrophy, amblyopia, optic neuropathy, cortical vision loss and functional vision loss. Macular OCT, macular ERG or multifocal ERG in patients with unexplained visual acuity loss should be considered, which can help in diagnosing patients with ocular macular dystrophy and other foveal defects. We emphasize the importance of this differential diagnosis in symptomatic cases with few or no fundoscopic findings. Currently, no treatment is available for patients with ocular macular dystrophy. The visual acuity for most patients appears slowly worsen over the span of 10 to 20 years and then remains stable. However, there is a significant variability that exists between patients, and larger and long-term studies are needed to better counsel the patients on their visual prognosis. Thank you.
Jasmith, how many days history he was having?
So he gave a history of around 2-3 months only.
2-3 months. Do you think that the dystrophy causes the sudden loss of vision bilateral in 2 to 3 months?
So he was actually a factory worker, and he told that my visual acuity was completely normal and suddenly deteriorated over the span of 2-3 months, and he just came for a normal checkup, and we ruled out that the visual acuity declined to 636.
Was he involved in welding welding work in the factory, or he was exposed to welding?
No, sir, he was not exposed to any welding. He was doing a technical work there, not exposure to any welding or anything like that.
What are the other findings you have got in favor of dystrophy?
So actually the OCT is the only significant finding we have here, and so actually multifocal ERG is not available at our university, so it could not be done. I also did a perimetry in this case, sir. So usually in ocular macular dystrophy the central scotoma is seen, but in this case the perimetry was completely normal, and we did an FFA also, but there was a mild hyperfluorescence seen at the foveal region. Other than that, there was no abnormality. So basically an OCT finding here showing a foveal thinning and loss of interdigitation zone is the positive finding in this case.
So according to you, it is a dystrophy only.
Yes.
It cannot be a phototrauma.
So he didn't give any history like that. He was doing only technical work, nothing like an exposure to a sun gaze. That's why I took a history of sun gazing or any eclipse viewing, or even if you're exposed to some welding things in the factory, but he didn't give any history like that.
These are very typical of welding arc
Right.
injuries, and bilateral symmetrical, and that too in a factory worker,
Yes, sir.
accidental exposure to this.
Could be a possibility.
Okay,
Sir.
thank you.
Thank you, sir.
Thank you. Nice presentation.
Next speaker is Mozammam Parvez. He will be presenting on the a generation of best disease.
Good afternoon, everyone. Myself, Dr. Mozam Parvez, and I'm here to share a case on a generation of Best disease.
Yeah, Your time starts now. Huh? You will get 5 minutes.
So in the OPD, our mother presented with 4 children, and all 4 kids had rotatory nystagmus and decreased visual acuity since childhood. They were presently complaining of photophobia, and immunization was up to date in all the 4 children. There was no history of any other chronic illness, and there was no other ocular complaints noted in both the parents. Genetically, all the 4 children had visual acuity impaired, and no complaints in the parents. On examination, all the kids had visual acuity ranging from 636 to 612. The pupil was found to be round, regular, and reacting, and the cornea was clear. The IOP was found to be normal within 17 to 16 mm of mercury. The anterior segment was found to be within normal limits. On investigation, a cycloplegic refraction was done for all the kids. IgG was noted to be less than 0.1. IgM values were found to be less than 1. And toxoplasmosis, gene typing, ERG, EOG, color vision was found to be suboptimal and decreased color sensitivity. So this is a fundus picture noting a punched out lesion in the center of the macula, temporal to the disc. On OCT, the same picture continued in all the 4 kids, where a punched out lesion was seen on the macula, which was hyperfluorescent. This is the fundus autofluorescence, again showing macular hyperfluorescence and punched out lesion. OCT was done. OCT showed RP lipofuscin deposits in the punched out lesion and RP abnormality. OCT-A was done for this patient, correlating the findings which were found previously in all the 4 kids. So best vitelliform macular dystrophy shows hereditary retinal dystrophy of the RPE, which involves abnormal chloride conductance and disrupts fluid transfers and accumulation of debris between the Bruch's membrane and the RPE membrane. Best phrenopathy, allelic variation in the bestrophin gene, best1 gene on chromosome 11q13, which is autosomal dominant, and it can also be due to VMG2 or TU15B and incomplete penetrance of the variable expression. The various stages of the best macular dystrophy: pre-vitelliform, where abnormal EOG with normal findings; vitelliform stage with solitary round or oval slightly elevated lesions at macula; pseudohypopian stage where the vitelliform deposits gravitate inferiorly in the subretinal space; vitelliruptive stage where vitelliform substance breaks up and scatters in a scrambled egg fashion with substantial drop in the visual acuity. Then comes the atrophic stage with areas of atrophy and pigmentation, and the last stage being the choroidal neovascularization, where subretinal bleed may be present due to choroidal neovascularization. Egg yolk appearance is seen in the stage 4, which is round and sharply delineated, and macular lesion of half to 2 disc diameter size at the macula. EOG for the patient showed Arden ratio less than 1 with light peak and dark trough ratio less than 1.5. So the management given to the patient was antioxidants. Genetic counseling was done for the kids as the visual acuity might drop further. Low vision aid, Amsler grid charting for metamorphoxia, and there is a role of anti-VEGFs if choroidal neovascularization develops in the future. Thank you.
In which stage these were punch out lesions, no?
Yes.
In which stage punch out lesions are seen in best dystrophy?
Stage 2.
Hmm?
Stage 2.
Stage 2 gives punch out lesions.
In the vitelliform stage.
Is it elevated or punch out?
Punched out.
What are the points in favor of your diagnosis of this case? How you have diagnosed as a case of series of Best disease?
Especially on the OCT findings where we saw the macular dystrophy.
OCT is not diagnostic of Best disease, particularly in this case series. Do you have any other diagnostic clue that or supporting evidence that is?
Only EOG. We could not do the gene typing as it's not available,
Did
and
you do
the
EOG?
patients could not afford it.
Did you do EOG in these cases?
Sorry?
Did you do EOG?
EOG less than 1.5.
All the cases?
No, one kid, not all the 4 kids.
Usually this type of pass out lesions are not classic of death vision, but
And the vision, how much was the vision?
Their age ranging from 11 to 4 years. Their vision was the eldest kid had 636, and the 4-year child had the 612 and 618 in both the eyes.
What says goes in favor of best or against the best? There is a disproportionately good vision in best cases. Even
Maybe
up to
visual
the
acuity
6,
will
7
drop
decade
further
patient is having
with
6 vision.
due course of time.
Yeah, but why it is at the 11 years or 13 years? He is 636. You have to find out the another differential diagnosis in these cases. Okay. Good luck. Thank you. Next speaker is Dr. Pragati Tiwari. Is she available here? Okay. She will be speaking on optic disc pit and related maculopathy. A case report with 6/9 vision. Okay.
Good afternoon, everyone. The topic of my paper is optic disc pit and related maculopathy. At
Can you
no
get your
financial
mic closer?
disclosures or
Can you get your mic closer? I'm sure people cannot hear you.
there are no financial disclosures or conflicts of interest. So, optic disc pit is a cavitary anomaly that was first described in the late 1800s. It's essentially a congenital anomaly with various associations like myopia and glaucoma. The prevalence recorded is found out to be 1 in 11,000 patients. The age group that is predicted to this is 40 to 50 years of age, and there is no gender predilection as such. Mostly the cases are unilateral, but bilaterality can be seen in 15% of cases. These cases are sporadic, but few autosomal dominant inheritance pattern has also been noted. Maculopathy related to optic disc pit that includes serous detachments or PEDs and pigmentary changes was first described by Halbertsman in 1927, and most of these pits have serious macular detachments. That is in the range is 25 to 70% cases, and more so in patients who have a OD pit that is located temporally. So moving on with the case, a 40-year-old female presented to her OPD with a complaint of shadow in front of her left eye for the last 7 months. She did give a history of laser treatment in the left eye 2 times in this duration only, with no other ocular complaints or no significant systemic history as well. On examination, the right eye was within normal limits. The left eye showed vision of 6 by 12 and best corrected to 6 by 9 with a plus 0.75 spherical. The contrast sensitivity was also reduced in the left eye, in the affected eye. Other than that, it was normal. We went ahead and performed a dilated fundus examination, which showed a normal right fundus, but the left eye showed a large optic disc pit located centrally with a large NSD. It also showed a few laser marks that the patient was giving history of. We went ahead and performed an OCT, and through the OCT we found the central retinal thickness of 809 microns, and we saw a large area of neurosensory detachment and also surrounding areas of retinoschisis. Another section showed a direct communication between the perineural space and the retinal detachment. The neurosensory detachment. So provisionally we came to a clinical diagnosis of left eye optic disc pit with maculopathy. Since the patient had a good vision, follow-up for visual assessments and serial OCTs, fundus and recording the fundus photographs, and the patient was found that there is connection between the perineural space and the subretinal space. The fluid can migrate because of vitreous traction or the pressure gradient that is present across this dysplastic tissue, and whenever there is rise in ICP, the fluid can migrate to the subretinal space. On searching the literature, we found that spontaneous resolution can occurs in 25% cases, and the patient can have consecutively posterior lamellar hoe or full thickness macular hoe. But that is also rare, And another literature showed that Block et al. They investigated the natural history and they found that 77% of patients maintained the vision of logmar of less than 0.3 without any surgical intervention, and in 59% cases who underwent surgical intervention, they achieved the same visual outcome. So to conclude, optic disc pit is a rare congenital anomaly and associated maculopathy can occur in 25 to 75% cases. Diagnosis is mainly clinical and OCT can be an aid to that. Management is conservative, but in certain cases we can go ahead with surgical management. Since 70% cases nearly retain the vision at the end of 7 years, we can manage them conservatively, but surgical options that are available in our armamentarium is parsplantar vitrectomy with endolaser and gas tamponade with or without ILM peeling. The results although are variable. Needless to say, a thorough dilated fundus examination with a special focus on the disc goes a long way. Thank you.
Why the patient has come to you? What was his main complaint
So
with the 6/9 vision?
So she complained of shadow and complained of shadow, not diminished vision, but a shadow in front of her eye, like a scotoma.
What,
That was the main complaint.
what other investigation would you have done?
So visual fields, we did perform visual field, but on repeating it twice, it was coming out to be unreliable. And we also asked her to draw the metamorphopsia. We tried to record it on Amsler chart. So she was recording wavy lines. Metamorphopsia, she was that was what we could record objectively.
Is there any role of angiography in these cases?
So if we are suspecting CSCR, we could rule out if there is a particular vessel that is leaking, and we could coagulate that. But in this case, we are very clear cut. We can visualize the optic disc pit and the connection, so can rule out that. But it can be done, sir, to rule out other causes of neurosensory detachment.
What's your plan in this case?
So for now, observation only. If she develops macular hole, then in the line of treatment, it can go in that direction. Or if she develops RD or her vision deteriorates, we can perform surgical management. In certain cases, there has been a role of macular buckling as well, but the results are variable, and that can be another option.
What will happen with the surgery, and if you don't do the surgery? At what stage you will consider the surgery? You mean that the macular hole, you are going to wait till the macular hole develops?
Not wait till she develops that, sir. But since she was retaining that vision, she was also not opting for the surgical option when we counseled her regarding the various options. So that was another.
Okay, good.
So, few more questions, doctor. So you said that if you'll observe the patient, when are you going to observe the patient? How long are you going to wait? Your next follow-up with this patient?
So monthly for her, we were
Monthly? You expecting the vision loss to progress that fast?
Not that fast, sir, but considering the size of the neurosensory detachment,
Will you decide that when the patient should undergo the surgery, or do you let the patient decide? So if the patient comes and says that I'm not happy with my vision, so is there anything you can do? Would you want to go in for surgery that time?
so we can perform because there are other changes that can happen, and with chronic anesthesia there can be loss of photoreceptor, and despite treatment her vision would be poor.
But your presentation also said that surgical results are variable.
So that's my point of that. The point of observation is that only, sir. Despite the results, the vision has been found out to be almost similar in most of the cases.
Don't get nervous. So what happens is these are tough cases to manage even surgically.
Right.
And even after you operate for them, there are recurrences even after that. So it's a wise idea to wait for now, for sure. But then you have to just keep a follow-up, explain to the patient that, the nature of the condition. Thanks.
Next talk is by Dr. Apurva A.G. Is she present here? Presenting author is Meghna Neurology. She is available? Not present.
Dr. Meghna?
Dr. Meghna. Okay. No.
Absent.
Next speaker.
Anybody from Joshi over here? Go to the next one.
Okay. Next presentation by Dr. Vivek Veldumani. He is present. Okay. He will be presenting on intraocular pressure changes after intravitreal dexamethasone, that is Ozurdex sustained release implant. Okay, doctor.
Morning, my paper is about the intravitreal ozurdex and the intraocular pressure changes after implantation. We have no financial disclosure with regards to the study. Intravitreal corticosteroids are being increasingly used for a number of posterior segment disorders, and the most common side effect observed is increase in the intraocular pressure. Ozurdex, coming to Ozurdex, it releases dexamethasone for a period of 6 months, and it is commonly used dosage is about 0.7 milligram and reaches the peak concentration about by 2 months. And the pharmacokinetics of Ozurdex is found to be similar in both vitrectomized as well as non-vitrectomized eyes. In this study, we have evaluated the incidence and risk factors for rise in intraocular pressure after implantation of intravitreal Ozurdex. This is a retrospective study conducted between July 2021 and December 2022. All the patients had at least 3 months of follow-up, and details such as demographic features, indications for Ozurdex, prior history of any glaucoma, and the baseline IOP at each follow-up, and the lens status and the history of vitrectomy were collected. Patients with having eyes with macular edema due to diabetic retinopathy, retinal vein occlusion, and non-infectious uveitis were included, and patients who had at least 3 months of follow-up were included in this study. Patients having vision worse than 20 by 200 and prior history of any usage of intravitreal corticosteroids and prior history of existing glaucoma and poorly controlled diabetes and systemic hypertension, and patients who had less than 3 months of follow-up were excluded from the study. So rise in IOP was defined as single measurement of more than 25 mm of mercury or an increase of more than 10 mm of mercury from the baseline. The baseline IOP and the IOP after 1 week, 1 month and 3 months after injection were analyzed. 30 eyes of 30 patients were included in our study, of which 28 eyes received a single dose of intravitreal Ozurdex and 2 eyes received 2 doses of intravitreal Ozurdex. Among those 28 eyes, 2 eyes had a IOP rise, and among those 2 eyes which received 2 doses had a single eye had a IOP rise. So on the total, IOP elevation was seen in about 3 eyes, which contributes about 10% of the cases, and they were treated with topical anti-glaucoma medications. The mean age of the study population was found to be about 54 plus or minus 15 years, of which 16 of them were male and 14 of them were female. The most common indication for Ozurdex in this study was found to be about non-proliferative diabetic retinopathy and proliferative diabetic retinopathy 2 cases, and retinal vein occlusion 4, and non-infectious uveitis 5. In our study group, 17 of the patients were having phakic and 9 were pseudo-phakic, and 2 of the patients developed cataract after implant with a mean duration of about 3 months, and 2 patients underwent vitrectomy after a period of 3 months. So for matter of convenience, based on the type of indications of Ozurdex, we divided as that group A to be non-proliferative diabetic retinopathy, and assumed B as proliferative diabetic retinopathy, and C to be retinal vein occlusion, and D as non-infectious uveitis. So this coming to this table, we see a post-operative spike during the post-operative spike of the intraocular pressure during the first month of the IOP, which is shown to be maximum in the group A, and it is statistically significantly different from the baseline IOP, and the IOP actually returned to baseline after the 60 days or third month. And we also tried to predict the IOP changes with the central foveal thickness during the first week itself. And the central foveal thickness was found to be reducing trend in all 4 groups, and there was a maximum reduction of the central foveal thickness in the group C, that is the retinal vein occlusion. So this is the fundus photograph of the patient having macular edema and the OCT with the central foveal thickness measured before and after. We can see the reduction in the central foveal thickness as well as resolving of the macular edema. This is a secondary visual outcome. All 4 groups showed a significant visual acuity improvement after the end of 3 months. This is the graph depicting that the majority of the cases were belonging to non-proliferative diabetic retinopathy, And the graph representing a peak in the post-operative first month, and the IOP actually returned to baseline after the third month. Central foveal thickness also, all four groups showed a maximum reduction in the central foveal thickness. Visual outcome was comparatively good in all four groups. And we tried to find a relationship between the intraocular pressure measured at the first week and the central foveal thickness measured at the first week. And there was a very small negative correlation was found out, but it was not statistically significant in our study. So in order to conclude, the IOP rise was not related to age, sex or indication of injection in our study, and the eyes receiving more than one injection were at significantly higher risk for rise in IOP. The limitations of our study is we are having a short follow-up period because we have to follow up the patients for about 6 months, but in our hospital we are unable to the patient, we had lost follow-up, so the loss of follow-up is a limitation, and the small sample size could be a limitation of our study. So to conclude, intravitreal ozurdex is safe and associated with rise in IOP. Only in small percentage of eyes and eyes receiving multiple injections are at higher risk of IOP rise and requires careful monitoring. These are my references. Thank you.
So before giving ozurdex, how do you evaluate the patient for like whether he's a steroid responder or glaucoma related? Now, before you give the ozurdex, what do you evaluate? Any patient of us, whatever you have given indication, will give ozurdex, or you have any patient who say will not give ozurdex because of glaucoma or something?
We have excluded the patients who are having already glaucoma.
You don't give. Then what do you treat with them? Those patients, what do you treat? How do you treat?
So we control first the
No, with the patient with the macular edema, with glaucoma you don't give ozurdex. How do you treat the macular edema?
We give on topical anti-glaucoma medications and we can start.
Ozurdex you will give. Piyush, you agree or Manoj? Yeah. No, history of glaucoma is saying you will give anti-glaucoma and give ozurdex.
No. There are any other options or other alternative medicines will you try?
Yeah.
Like anti-VEGFs or any other lasers, anti-VEGFs, or you give directly ozurdex?
We can try a trial of anti-VEGFs and then can go for it.
Okay. And before that, what sir was saying, that you have to do this is steroid responder challenge test. You can keep on putting the drops for 1 week, 2 weeks, steroid drops, 2 hourly, 3 hourly, 4 hourly, and then see whether the patient is having steroid responder, and then you inject. Otherwise, it will be hazardous. Okay, thank you. Meghna, Niralabi. The next patient, Meghna, is present? No, she is absent. Okay.
Dr. Meghna?
Dr. Meghna is not there. Okay. The next speaker is?
From Joshi's place, no?
Yeah.
Guru Prasad,
No one has
good
come.
team, not there?
Okay, 5 minutes to go. Okay, we have 2 speakers. And the next speaker is Dr. Sachin Mauli. He is present? Dr. Sachin Mauli? No.
Mascarinus.
No. Next speaker is Arati Panir Selvam. She will. Okay. She will be presenting on topical steroid as primary treatment for Koyanagi-Harada syndrome. You can start the time.
Good afternoon to one and all present here. So my topic for today is topical steroids as primary treatment for Koyanagi-Harada syndrome. We have got no financial interest. So as we all know, VKH syndrome is idiopathic multi-system autoimmune disease featuring inflammation of the melanocyte containing tissues such as the skin, uvea, ear and the meninges. And based on the diagnostic criteria, revised diagnostic criteria, we classify them as complete VKH, incomplete and probable VKH. So today, the materials and methods, our study was conducted in Vijayalakshmi Eye Hospital, Trichy. We assessed the effectiveness of subtenon triamcinolone injection 20 mg in 10 eyes of 5 patients who were diagnosed as a case of probable VKH syndrome. So I'm discussing few case scenarios. So our first patient was a 32-year-old female who presented with complaints of defective vision for the past 1 month. Her systemic examination was normal. Visual acuity, right eye was 6/60 and left eye was 6/12. Anterior segment examination revealed mild anterior uveitis. In fundus, the media was clear in both the eyes. The disc margins were blurred and they were hyperemic. And you can also see the accumulation of fluid around the macular in the posterior pole. And in OCT, you can see multiple pockets of subretinal fluid, and there is the loss of foveal contour. RP irregularities were present, and also ILM fluctuations were noted. The second patient was a 33-year-old male with complaints of defective vision in both the eyes for a period of 1 week. Systemic examination was unremarkable. Visual acuity, right eye was 6/36 and left eye was 3/60. Anterior segment examination was normal. Fundus showed loss of foveal contour, and there are also multiple pockets of subretinal fluid in the posterior pole. And OCT also, as you can see compartments of subretinal fluid, RP irregularities, and also the foveal contour is lost. The remaining 3 patients also had a similar picture of fundus photo and OCT. So management, so all our patients, we did systemic investigations to rule out any other comorbidities, and we subjected them to subtenon injection triamcinolone 20 milligram in both eyes under aseptic conditions. And we also gave them topical difluprednate eye drops for 1 month, and for 1 month which was tapered, and 1 patient alone needed an extra dose of the injection. The patients were followed up to 1 year, and the visual acuity post injection was 6/6 in almost on all the patients. So you can see the pre-injection and the post-injection comparison of fundus photo and OCT. You can note that the vision has considerably improved to 6/9 in both the eyes on the 9th day, and the OCT is almost normal, and there is a significant reduction of the subretinal fluid. And this is also the photo and OCT of another patient. Here also you can see the OCT, in the OCT the fluid has reduced and the vision has also improved. So coming to discussion, VKH syndrome is a multisystem autoimmune disorder involving various skin manifestations, CNS and auditory sign. Systemic steroids are usually the mode of treatment, but we have got various side effects such as hyperglycemia, hypertension, immunodeficiency, raised IOP, and also cataract. And tapering of if steroids not given adequately and not tapered can result in recurrence. And immunosuppressants also have similar complaint, where if you are not giving it adequately and follow-up is not proper, then it can result in recurrence. And also the drug availability, cost factor, patient tolerance is also a problem when it comes to immunosuppressants. So the major advantage of posterior subtenons is that a higher concentration of the drug is delivered to the posterior segment of the eye via transscleral absorption, and there is minimal side effect. And it is available as an aqueous suspension, and it is safe, and it is a minimally invasive treatment when compared to systemic steroids and also immunosuppressants. Conclusion, I would like to say that primary subtenon injection is a useful and a minimally invasive mode of treatment in VKH patients without any systemic steroids. So we can consider them for probable cases of VKH. Our study has got several limitations because it has a smaller sample size and a shorter follow-up. We would like to do a future study with a larger sample and also a longer follow-up, and which will help us to confirm that we can consider subtenon triamcinolone as a mode of treatment in probable VKH patients. Thank you.
Thank you very much.
Okay, we have a paucity of time, so we move on to the next speaker. Thank you, doctor.
Thank you. Thank you.
Dr. Pragati Raj. Is Dr. Pragati Raj there? Yeah.
She will be presenting on closing the young fovea. Okay, very good.
Good afternoon, everyone. Today I am here to present about the closing the young fovea. traumatic macular hole is a well-recognized condition after blunt ocular trauma. Unlike an idiopathic macular hole's gradual progression, TMH is caused by sudden eyeball compression and usually occurs immediately after trauma. There is an ongoing debate regarding the need for vitrectomy or observation for its management. So primary aim of our study was to see the anatomical and functional outcomes of pediatric TMH with current treatment guidelines, and secondary aim was to study the rate of spontaneous closure and type of closure after surgical intervention, and to study the correlation of base diameter with preoperative visual acuity and functional outcome of pediatric TMH. It was a prospective interventional study, inclusion criteria being age under 18 years, history of ocular trauma associated with decrease in visual acuity, and a well-documented full-thickness macular hole seen on ophthalmoscopy and SDOCT. Exclusion criteria was age above 18 years, idiopathic macular hole, open globe injuries, any media opacity deterring with measurement of OCT parameters, history of any vitreoretinal surgery, high myopes, and patient who were unable to maintain the prone position after surgery. 14 eyes were selected and taken in our study with complete ophthalmic examination. BCVA recorded pre and post-op on Snellen and converted to logmark. Presence absence of Weave's ring, Berlin edema, extrafoveal hemorrhage or choroidal rupture was noted. SDOCT parameters noted were base diameter, minimum linear diameter, presence or absence of cystic edema or fluid cuff, and posterior vitreous detachment. So this is the picture showing A being the MLD that is measured at the level of outer segment of photoreceptors, and B at the level of RPE. And B is the base diameter. The baseline parameters include mean age of the patient was 14 years, pre-op BCVA was 1.09, post-op BCVA was 0.69, average BD was 1387, MLD was 602, and 6 cases had cystic spaces and 9 had fluid cuff. A 3-month observation period was advised to each patient with own risk and benefits explained in unbiased manner, and a monthly follow-up was advised. Observation was to see if there was any occurrence of RD, enlargement of hole or decrease in BCVA. 11 out of 14 patients were taken for surgery and 3 were found to have spontaneous closure within the observation period, and 1 was taken for surgery within the observation period because of retinal detachment. Written consent was taken. 23 gauge 3-port VPV with ILM peeling was done. Triamcinolone assisted PVD induction was done. ILM stain with BBG for 45 seconds, and ILM peeling was done from arcade to arcade with a flap of ILM draped over the MH. FAE was done, and 10 out of 14 patients had C3 F8 tamponade, and 1 with the RD had silicon oil tamponade. This is the flower petal technique of ILM peeling. Patient was advised prone positioning for a week and was reviewed on day 1, 7 and 12 weeks after the surgery. Post-op BCVA and OCT parameters were taken at 12 weeks in the study. So this is the picture showing type 1 closure at with no residual neurosensory defect, and type 2 closure with residual neurosensory foveal defect. As a result, we found that the incidence to be more in male, that is 71%. Spontaneous closure rate was 22% in the surgical cases, 27% had type 1 closure, 55% had type 2 closure, and 18% cases where there was a failure to close. The graph shows improvement in visual acuity in cases of spontaneous closure. This is the graph and the tables showing the significant correlation between pre-op and post-op BCVA that shows the improvement in visual acuity after hole closure. The table shows a significant correlation between base diameter and pre-op BCVA, showing that as the base diameter increased, the pre-op visual acuity dipped, and same goes with the base diameter with post-op BCVA, that was even more significant, and so it shows that the visual gain after surgery was not that much as compared to those which have the lesser base diameter. So collaborating with the previous literatures, the incidence of pediatric TMH is more in males than females. About 22% of our cases went for spontaneous closure in a mean duration of about 50 days from trauma, and as the base diameter increases, the visual acuity decreases. So we need not hurry for surgical intervention in a case of pediatric TMH. Base diameter is inversely proportional to the visual outcome of the surgery, and newer surgical techniques like multi-layered ILM peeling has improved anatomical and surgical outcome. Thank you.
One question. We'll just take one question. If anybody has one question, then we'll end the session. So,
How many days you want to wait before doing the surgery?
Sir, there are 2 protocols that are currently being followed, either 3 months or 6 months. We waited for 3 months, and after that the patient were advised and given a full unbiased opinion about the surgery, if they wanted to go for surgery or should wait for the 3 months more.
What is observed in first 3 months?
Sorry, sir?
In first 3 months, what do you observe?
So any visual decline, and then the OCT was done at every month to see the base diameter and MLD, if there is any increase in the base diameter or MLD, and to this periphery was screened for any breaks or chances of retinal detachment. And in that case, we intervened earlier.
Okay, good. Thank you very much.
Thank you.
with that, we come to the end of the session. I would like to thank our chairperson, Dr. Natarajan, our co-chairperson, Dr. Malika Goyal, convener, Dr. Manoj Sasavre, Dr. Manab Jyoti Burman, the co-convener, and myself, the moderator, Dr. Piyush Bansal.
Yes.
We
Thank
can,
you.
we can take the hall for the next session.